So, very good evening to you. It's a pleasure being here and grateful to the organizing committee for giving me this opportunity. I'm going to speak on superselective intraarterial chemotherapy for retinoblastoma, when and how. I come from the All India Institute of Medical Sciences in Delhi. So as we all know, the goals of therapy of retinoblastoma are life salvage, globe salvage, and vision salvage wherever it is possible. Of late, there has been a paradigm shift towards globe salvage treatment modalities in retinoblastoma that has helped us in conserving a lot of eyes that have otherwise would have had to undergo enucleation. So what are these treatments? One of these treatments that is now becoming very popular all over the world and is also being used in some centers in India is super selective intraarterial chemotherapy. And essentially what this entails is delivery of targeted chemotherapy to the eye via direct cannulation of the ophthalmic artery. So this was a landmark paper published more than 10 years ago, and this was the New York group with Dr. Abramson and Dr. Gobin who first described their experience of intraarterial chemotherapy for management of retinoblastoma. And after that, there has been an interest all over the world in incorporating this treatment into the routine management of retinoblastoma cases. Now, why IAC is the question. So first of all, we all understand that whenever we try to save an eye with chemotherapy, if we are giving it through the intravenous route, we are exposing the child to the dangers of systemic toxicity. And here the retinoblastoma is just limited to the eye. So if we are able to deliver targeted drug just to the tumor and avoid the side effects of systemic chemotherapy, that would seem to be an ideal situation. So this IAC enables us, it offers us the chance to use high concentration of the drug at very low doses. And when we say super selective intraarterial chemotherapy, it was initially devised by the Japanese and later modified by the American group. And what they actually do is insert a microcatheter right into the ophthalmic artery, and thereby they're able to deliver the chemotherapy drug into the artery of ophthalmic artery that just goes and then enters the tumor. So now, obviously, not all cases of retinoblastoma can be given intraarterial chemotherapy. So here the question is that who can benefit from intraarterial chemotherapy and what are the important considerations? So first is a careful case selection, and the second is that we need a multidisciplinary team that consists of an ocular oncologist, an interventional neuroradiologist who can actually do the procedure of intraarterial chemotherapy, an anesthetist and a pediatric oncologist to look after the systemic issues that may arise because of the procedure. So when it comes to the exclusion, we have a checklist. Obviously, if it's advanced retinoblastoma, there's already anterior chamber invasion, there's secondary glaucoma, phthisis bulbi, aseptic cellulitis, optic nerve invasion, or frank extraocular disease like we already have in many of the advanced cases of retinoblastoma who come to us. The tumor has already spread beyond the eye, so there is no question of trying to save the eye. Here you want to save the life of the child. So in such cases, we cannot recommend intraarterial chemotherapy. Now the real challenge comes in the development of setting up a multidisciplinary team. Like I told you, it is a kind of collaborative work between an ophthalmologist, a neuroradiologist, and a pediatric oncologist. So luckily, at All India Institute of Medical Sciences, we have a team where we have been doing this procedure for almost the last 10 years. And we have a very skilled interventional neuroradiologist who's helping us develop this facility at our center and providing it at a very nominal cost to our patients. So here's a short video where I will just show you how this procedure is done, and I would like to acknowledge the neuroradiology lab where this video has been shot. So the child is, of course, first under general anesthesia. The procedure is done. These are the things that are used for the procedure. There's a guiding catheter, there's a guide wire, there's a microcatheter. And here you can see, under fluoroscopy guidance, the femoral artery is actually punctured on the side of the ophthalmic artery. And through the femoral artery, there's a catheter which goes, if you remember your anatomy, it goes right through the aorta. Here it's going through the abdominal aorta, the thoracic aorta, and then, if you remember, the ophthalmic artery is a branch of the internal carotid artery. So from the aorta, it has to actually reach the internal carotid artery. And from there, then, it has to the catheter has to actually reach the ophthalmic artery. And you can imagine this is a child, how thin and friable the ophthalmic artery of the child would be. So how much of skill and expertise is needed on the part of the interventional neuroradiologist. So what you can see over here is that a dye is, once the catheter is in position, a dye is being injected. This is the cerebral arteriogram, and it shows the vascular supply, because sometimes children have an aberrant vascular supply, and the ophthalmic artery may not be arising from the internal carotid artery. So the whole idea is to understand the angioanatomy before actually injecting the drug, to make sure that it is entering the correct place. So here you have, this is the catheter, it is going in, and once it is in position, then it is placed there, the ophthalmic artery is hooked. Here you can see the dye is being injected, and this is showing that it is right inside the ophthalmic artery. Melphalan is the most common drug that is used, although we also use some other drugs. It is freshly prepared at the time of the procedure, and then it is infused over a period of 30 minutes. So this is briefly how the procedure is done. And why do we use melphalan? Because in vitro studies have showed its greatest effect on retinoblastoma cells. Nevertheless, systemic use of melphalan is limited because of severe myelosuppression. It cannot be used through the systemic route, although it is very efficacious, and hence it is a drug of choice to be used through the intraarterial route. Now, this is how we prepare. Broadly, age-wise, the concentration of melphalan, but mostly children with 1 to 3 years get a dose of 4 milligram. And sometimes we need multiple sessions. In fact, usually one session doesn't suffice. We do go up to 3 sessions. Sometimes we also top it up with other drugs like topotecan and carboplatin, but the initial drug of choice is melphalan. So this is one case of a 2-year-old boy. He had a group B retinoblastoma. Initially, the cases that we did were all one-eyed patients, and they were kind of desperate cases for globe salvage that had failed systemic chemotherapy. Now, of course, we are using it more commonly. We are offering it even as a primary treatment in some of the cases. So in this patient, again, you see over here that, the tumor had failed systemic chemotherapy. It was right at the posterior pole. And this is the response that we had after IC. It was all stable then at 2 years of follow-up. This is another similar case of a 2-year-old girl that benefited from this treatment. The tumor responded to IC. It had not responded to intravenous chemotherapy. This is another such case. You can see the tumors regressed on the top after systemic chemotherapy, but this tumor that was still active then was treated with IC. Of course, one has to be very wary of complications, and it cannot be done, kind of without the backup of a good pediatric oncology setup. There can be anesthesia-related complications, there can be vasospasm, thromboembolic phenomena, there can be ocular complications, there can be a hematoma formation at the femoral artery. So one has to be ready to tackle these kind of complications. It's a technically challenging procedure, and so all these things have to be explained to the patient. Another child who developed a third nerve palsy after the procedure, after day 7, but most of these things, they resolve on their own. Like in this case, after 3 weeks, the child was doing absolutely fine. Now, technically, like I mentioned, it's a very challenging procedure, so there are instances of failure of cannulation because of small artery of the ophthalmic artery. It could be a steep takeoff from the IC, and sometimes there's an alternate vascular supply to the eye through the middle meningeal artery. So this is one article that we recently wrote for Dr. Yanov's book on intraarterial chemotherapy in retinoblastoma. So you can check out on more about this procedure from here. And for an international perspective, we also have this intraarterial chemotherapy in our upcoming book, Global Perspectives in Ocular Oncology. That's my colleague from Harvard Medical School, Dr. Mary Arano, who has co-edited this book with me. And before I end, just 2 important announcements. Tomorrow we have an inaugural session for the Eye Cancer Society of India. So if we invite all ocular oncologists, ophthalmologists, and everybody who's interested in learning more about eye cancer treatment or in contributing to the awareness of eye cancers in India is most welcome to join us. We would be delighted to have you there. We also have an upcoming webinar which is going to be the first virtual symposium on the Asian retinoblastoma group. My colleague Ido Didi Fabian has joined me in arranging this webinar, and this is going to be held on January 15, 2023. We have many countries all over Asia where experts would be joining us either as presenters or as panelists, and I hope this is going to be of interest to all of you. This is the link that is available. Thank you all for your kind attention.
All right, yeah, so my topic is orbital inflammation and enigma, and I'll take you through a few cases, very interesting cases, okay? And I see most of you are postgraduate students here. Okay, all right, yeah. So when the nation was gripping, in the fear of mucormycosis, and it was actually declared that mucormycosis is an epidemic, and anything which was coming as, acute presentation was considered as mucormycosis. So was this case. A 65-year-old gentleman, all right, in September 2020, he started with acute onset pain and swelling. And then he developed, having a third nerve palsy. And when he was referred to me, he was referred as a case of mucormycosis, all right. He was uncontrolled diabetes mellitus. His ppbs was 300 milligram per deciliter when he actually presented. And this was in October 10th when I saw him in the clinic when it got referred. His best corrected visual acuity was 6/24. Pupil, there was no RAPD, and optic disc margins were blurred. And this is exactly how he presented. Well, a diabetic, mucormycosis could be a possibility, severe pain, rapid progression. So what do we do next? Okay. Now, clinical evaluation, as you can see here, there is severe motility limitation over here. There is no supraduction at all right? So there is definitely a fullness in the superior orbital orbit as well, hyperemia, pain, etc., etc. So what you think is of an orbital inflammation? Of course, yes. Now, what do we do next? We go ahead doing an imaging. So this is what the imaging shows. There is a large diffuse lesion sitting in the superior orbit, okay, in the preseptal as well as the postseptal into the orbit, and this is how it was looking like. Now, what is remarkable over here? When you talk about mucormycosis, we say rhino-orbital mucormycosis. Sinus should be involved, mostly sinus is involved. You see, the sinus is absolutely clear. Usually it comes from the ethmoid sinus into the medial orbit, and that's how it progresses. I'm sure everyone knows about mucormycosis by now because you all have seen it, you have treated it. Sinus is absolutely clear, all right? So I was not too comfortable about the diagnosis of mucormycosis. So what I did was went ahead doing a biopsy, and this is what we did, an incision biopsy, all right? So this came out as a natural killer T-cell lymphoma, a primary orbital. No systemic involvement because we do a lot of systemic evaluation, including a PET scan in this patient. So it was a stage 3, T3N3 and M0, all right? So it was an orbital inflammation. It presented as an orbital inflammation, but on biopsy, it was proven to be a very lethal lymphoma. This is a very high-grade lymphoma. In fact, the patient died after 2 months of treatment, and this is how we go through it. We do a histopathology, and natural T-cell lymphoma, killer T-cell lymphoma needs specific immunohistochemistry, all right, to rule out the type of the lesion. So basic histopathology is not the only thing that you do for lymphoma. The tissue has to go for immunohistochemistry to type it. Now, this is a similar case, a 48-year-old lady. She was complaining of watering for 4 months, eyelid swelling 1 month. You can see that some amount of puffiness in the medial, canthal area and the superior medial orbit, and a little bit of swelling over here. And she has a history of nasal block, allergy, recurrent sinusitis, history of DNS. She is being seen by ENT, there is septal thinning, and she has a strong family history of cancer. All right. So with the septal thinning and with the ENT and stuff, what we would think is that there is an inflammation, we would think of Wegener's. Wegener's is something which arises in the nose with septal thinning. There is a lot of destruction there. And then obviously orbital inflammation. So there was an inframedial mass palpated. Okay. It is right here. Very subtle mass which is seen over here, non-tender, immobile, and she has watering. So when she was referred to me, she was referred as a case of dacryocystitis. Okay. Well, I did syringing. It was freely patent. We did CT DCG, which was not with a normal limit. So it's definitely not dacryocystitis. But there is some mass sitting over there. So what would I do? CT was done. There was a polyp in the nose. So the working diagnosis, as I told you, was Wegener's granulomatosis, probably a fungal granuloma or probably a benign tumor. All right. Went ahead doing a surgery. So that is the lesion, which was peri-sac. I could protect the sac, and this was a triangular lesion, a very fleshy lesion which was excised. You know what it came as? Natural killer T-cell lymphoma. Peri-sac extension, okay, and she received systemic chemotherapy, SMILE, stereotactic radiotherapy, but she eventually, in 8 months, developed peritoneal metastasis with CNS involvement. Within 14 months, she died. So this was a case which presented as a dacryocystitis, but there was something really hidden inside the orbit, and the polyp that she had, further she went to ENT, the polyp was removed, and that was actually a natural killer T-cell lymphoma again. Alright, so natural killer T-cell lymphoma, it's usually a midline granuloma, lethal granuloma. It arises in the nose and then it extends into the orbit. So, well, it's a very progressive necrotic granuloma, very, very lethal disease. Alright, I'm not going into the detail of it. So, ocular adnexal lymphoma mimics inflammation, and that is why it's an enigma. Biopsy always reveals the mystery. So, whenever you're kind of doubtful or inflammation, you gave steroids, it's recurring, always go for biopsy. Always refer the case if you're not able to manage. It might be something hiding inside. Now, this is a 50-year-old gentleman, pain and redness for 2 years in the right eye. Proptosis, 6 months. Diminution of vision since 1 week. Referred. Well, it's progressing and whatever. So this is what I found, a large lesion in the inferior orbit, and this is a typical kind of a, salmon colored appearance. There is a dilated vessel over here. So you know what, with the imaging, I thought, well, I've cracked it, and it's a lymphoma. All right, very diffuse lesion. We say whenever the lesion actually wraps around the globe, that's a typical imaging appearance of lymphoma. It's lymphoma. So I was like, okay, I cracked the diagnosis clinically. Fine. So I was so confident, but still I wanted to type the lymphoma, etc., etc. And I went ahead with the biopsy. So this lesion was excised with an, inferior pharyngeal approach, and then a little bit of biopsy from this area, and the lacrimal gland was also taken. And this came out to be this. So there's lots of fibrosis over here. There's no atypical small round blue cells over here. There is inflammation, fibrosis, inflammation. Okay, so we did immunohistochemistry. So any very painful, long-standing inflammation of the orbit, a new entity that we often rule out is IgG4 disease, all right? And we do an immunohistochemistry specifically for that, even if it comes as IOID. And this came out to be an IgG4-related disease. And the serum IgG4 was also high. So although it presented and looked like a lymphoma, it turned out to be an inflammation and something very specific. So he was on oral steroids, intravenous methylprednisolone, azathioprine, and he pretty well, responded to the treatment. So this patient was biopsied elsewhere, idiopathic orbital inflammatory disease confirmed, and then he was not responding to the treatment. So he was referred to me. When he presented, his best corrected visual acuity was 6/60. He also had optic neuritis associated with the orbital inflammation, all right? So this is the lateral rectus which was involved. He was already biopsied and proven. Now, what happened was that when he came to me, he had already received 2.5 grams of IV methylprednisolone. We can go up to 7.5. So what I did was, because of the severe unbearable pain and the vision, the optic neuritis, I started him on IVMP again. All right? He was responding for some time, but he progressed. He came out with a superior orbital fissure syndrome and an orbital apex syndrome, something like a Tolosa hunt. Very severe pain, complete ptosis. The eyeball was not moving because of the superior orbital fissure syndrome. Now, I'm in a fix, whether we are missing a diagnosis, whether something more is happening inside. I went again inside, okay? I took a biopsy, a superficial, a deepest, how much ever tissue that I could get. And this came out as an orbit IgG4 disease. What happened initially was only a basic histopathology was done. They never ever expected about an IgG4 disease. So immunohistochemistry was not done. A serum IgG4 was also not done. So this turned out to be an orbital IgG4 disease, which was fast progressing, involving optic neuritis. In fact, he's with injection rituximab. He's doing pretty well. I don't have his current picture, but everything is feeling better, and he's 6/6 vision with normal color vision. So this is something that I really wanted to highlight, especially with the PGs. So it's just not IOIDs that we talk about now. There is another entity called IgG4 disease also. So orbital inflammatory disease, to summarize, there is specific and non-specific. Specifics you have to always rule out. If you don't have the specifics in your hand, then it becomes a non-specific idiopathic orbital inflammatory disease. And you know what? 30 to 40% of biopsied inflammation has a specific disorder. So if there is something which is not responding, it's recurring, it's always good to take out a biopsy and prove the diagnosis. So the take-home message is, it can present at various clinical presentation: inflammation versus malignancy, malignancy versus inflammation, specific diseases, and all these things have to be ruled out, and a thorough systemic evaluation, depending upon the specificities, has to be done. Thank you so much for your patient listening. May I invite the next speaker? Yeah, Rolika on the stage.
So good evening, everyone. Yeah, hi. So good evening, everyone. So my topic was plaque brachytherapy in ocular tumors, and I've kind of, due to shortage of time, aligned it to ocular surface tumors, and I'll be talking on that. And I thank my mentor for giving me the opportunity of presenting these cases and of seeing these wonderful cases and his procedures. We have no conflict of interest to declare. So plaque brachytherapy basically involves radioisotopes, that is iodine, palladium, cesium, which are photon emitters, ruthenium, strontium, that are beta emitters, and they have variable half-lives, as we can see over here. So indications of plaque brachytherapy basically involve surface neoplasms like ocular surface squamous neoplasia, conjunctival melanoma, and intraocular tumors like uveal melanoma, retinal and choroidal hemangioma, retinoblastoma, ocular metastasis, and vasoproliferative retinal tumors, and we have successfully treated all of these lesions, I must proudly say. So talking about primary plaque brachytherapy, this basically is when we have proven corneoscleral invasion on clinical examination and with supporting imaging. So we know for sure that the patient has invasion, and we have decided that we will do plaque brachytherapy along with surgical excision. So in the same sitting, we do plaque brachytherapy and excision, that is called primary plaque brachytherapy, whereas secondary plaque brachytherapy is histopathology guided. That means that you're not sure clinically, and then pathology shows that yes, there is invasion present, and you must go ahead with secondary plaque brachytherapy, and then we schedule the patient again. So high rate of local tumor recurrence is related to high rate of metastasis. We must keep that in mind. Talking about ocular surface squamous neoplasia, which is basically premalignant and malignant epithelial tumors of conjunctiva, dysplasia, carcinoma in situ, and invasive squamous cell carcinoma are the ones which are part of the spectrum. So superficial lesions usually are treated by topical treatment or excision, and deeper lesions like the ones that I'm talking about, the corneal stromal invasion, are treated by primary or secondary plaque brachytherapy. So this is where I'm going to take you along how we exactly plan and post the patient. So first comes the clinical diagnosis. So diagnosis, tumor dimensions, documentation, and I'm just going to explain all of it. So first the diagnosis is made. An ocular surface squamous neoplasia is basically a pinkish vascular elevated mass with limbal corneal involvement. You must note down the involved clock hours. Rose Bengal positivity must be confirmed. Keratin on surface can be present, and prominent feeder vessels can be seen. And this next step is how to assess the extent of the lesion. We must know about the tumor dimensions. It can be proven on slit lamp assessment itself, and we can take the help of anterior segment OCT to confirm the corneoscleral invasion. And then we go to documentation. We consider documentation as a very, very important part. The same patient cannot come back with the same lesion again once you operate. So documentation is mandatory. And then we go ahead with dosimetry planning. We take the help of a radiation oncologist, we plan it out, and we make sure that we plan according to the extent of the lesion. If it's a diffuse lesion, we might have to rotate the plaque, and therefore the dosimetry planning is mandatory. Next comes the surgical extent. So over here, this was a patient who presented with the recurrent biopsies done elsewhere. He was not treated with plaque brachytherapy ever, and he kept having recurrences. And over here you can see we've gone beyond the lesion by 4 mm clinically clear margins. We have to meticulously excise it. Due to the repeated surgeries, there were multiple adhesions. As you can see, the lesion is quite vascular. This was not an easy surgery. It was in quite a diffuse lesion, so we had to plan rotations as well. You can see that there was lateral rectus involvement as well, and we had to excise the lesion of the lateral rectus very carefully, taking care that the muscle should be secured. We have secured the muscle over here, as you can see, and the involved segment, which was proven on MRI, the extent was proven, and that much section was taken off. And carefully lamellar sclerectomy was performed. This is a very difficult and slow dissection which is required. And with the lamellar sclerectomy, the lesion was completely dissected of the sclera. Over here you can see that very nicely we have to take care of the keratome moving on to the sclera. And then we had to put the plaque based on the previous dosimetry planning. And again, this patient underwent 3 rotations. So you can see the first one, the second one, and the third one. These are the ones which have covered the entire involved surface. And the plaque is placed for a particular duration and removed after the estimated duration. We do not go beyond the required duration, because we have to avoid the possible complications as well. And these are the rotations. And after the plaque is removed, it is securely transferred off to the plaque keeper. And then we have to do the surface reconstruction as well. So as you can see over here, we have to take care of the third, we've done the third rotation, and we had to take care of the margins which were treated with cryotherapy. And here the margins are completely taken care of. The muscle is secured, and the surface is reconstructed with amniotic membrane graft. So this was the surgical insertion, not an easy surgery. We had to go in for like 5 settings. Regular follow-up is mandatory. Now this is post-operative 6 years. So you can imagine the patient who had had like 3 recurrences came back to us. We treated with plaque brachytherapy, 6 years, excellent outcome. And we must document the comparison. It is quite important. So this is a study where we have seen that type of plaque was used randomly. In our study, we have used ruthenium plaque to be specific, and we have not seen scleral and corneal, we have not seen any of the cases with recurrences, and post-operatively, the patients are doing well. Similarly, about conjunctival melanoma, which is a rare lethal malignancy, less than 1% of the whole body melanomas, and the incidence ranges from 0.4 to 0.8. Very rare, but very important and very lethal. It presents as a dark pigmented flat or elevated lesion with a prominent feeder vessel with intrinsic vascularity, scleral fixity, and the corneal involvement must be noted. Again, by ultrasound biomicroscopy, you can see over here this was a patient who presented with an intraocular extension as well. And then ASOCT confirms. Histopathology, as I mentioned in secondary plaque brachytherapy, histopathology can show the base involvement. It is proven in all our cases. So the patient was dealt with primary surgical excision with or without cryotherapy, adjuvant radiotherapy. Earlier enucleation was the option, and over here we have been able to eliminate the possibility of enucleation and exentration successfully. And genetics guided target therapy is also used. In our cases, as we have seen, the tumor height has ranged from 4 to 17 mm and tumor diameter and tumor height. And this was a case that I'm going to skip due to the lack of time. And again, plaque brachytherapy has shown excellent results in our cases. And over here, even though the patient presented with diffuse involvement, the patient is doing extremely well. And this was a 14-year-old child. So in our cases of conjunctival melanoma, at an 8.1-year follow-up, the patients are doing extremely well with no recurrence, no metastasis whatsoever. So what we advocate to conclude is that 4 mm clinically clear margins must be taken with a good lamellar sclerectomy, alcohol keratoepithelectomy if there is a corneal involvement, double freeze thaw cryotherapy to the edges and the base for the involved area, adjuvant plaque brachytherapy, that should be used either as primary or secondary, and histopathological confirmation is mandatory. So this is multimodal management which should be used for ocular surface tumors. And we must actually thank that this procedure used to be earlier very expensive, and thanks to the coordination with BARC since past 2.5 years, we've been successfully doing all the cases in India with Make in India plaque. So thanks a lot. Thank you for bringing it in India. Thank you, sir. Any questions for me? Thank you. Over to you, ma'am.
Very good afternoon to all of you. At the outset, on behalf of local organizing committee, I welcome you all for taking so much pain in extreme cold condition to come to Patna. You all know there is paradigm shift in the management of OSSN, especially after development of good chemotherapeutic agents like mitomycin C, 5-fluorouracil and interferon. And with advent of HROCT, again diagnosis of tumor is very easy. So I will not take much time. Coming to the management part, previously surgical management with basically typically it was required removal of tumor with wide excision and cryotherapy of the limbus or corneal surface. But in a study published in Expert Review of Ophthalmology, it was found that in 2003, only in 66% of cases were managed with surgery, while in 2012 it came down to 51%. In another study, why this medical management is important, it was found that even if there is negative margin on histopathology, chances of recurrence is high, as much high to 33%. compared to with positive margin in 56%. So why medical management is important? So medical management basically they treat whole surface and some area which are inaccessible like palpebral conjunctiva, fornicage, caruncle, or there is diffuse involvement in which surgery is difficult, so medical management is helpful. There are surgical complications also, eye wall thinning, similar front formation, limbal stem cell deficiency in larger tumor. There may be corneal opacity also, and there may be damage to sclera, retina due to excessive cryotherapy. There may be pyogenic granuloma formation. So what are the agents that is available for chemotherapy? Most important one is interferon alpha 2b, 5-fluorouracil, mitomycin. Newer agent, some newer agent has also been quoted in some study, especially anti-VEGF, retinoic acid, and even aloe vera has been used for OSSN. So not going in detail about the mechanism of action. So coming to the first case, a 73-year-old male who basically father of my friend who presented with this large tumor, and so patient was taken and on OCT one can see the hyperreflective epithelium, and there is abrupt transition of normal epithelium to the abnormal to normal epithelium. So patient was put on interferon alpha 2b, and after 1 month one can see the size is decreased. After 3 months and after 6 months lesion has gone. So in second case again this was very large tumor involving the upper part of the cornea, bulbar conjunctiva, fornicage, and palpebral conjunctiva. This patient was put on mitomycin C 0.04%, and at 1 month again lesion decreased in size, and after 3 months lesion has gone. In third case again at presentation there was corneal involvement that was detected on OCT. One can see the thickened and hyperreflective epithelium. So again at 1 month lesion decreased, and at 6 months due to residual opacity is there, but lesion is gone. In case 4 again this was a case of xeroderma pigmentosa, and patient was non-compliant, and patient presented with recurrent OSSN. So initially we have started interferon, but patient was non-compliant, so again patient was shifted to mitomycin C. So after 5 months again lesion resolved. Fifth case again 51-year-old male, surgery was done outside, and patient has presented with recurrence. So again patient was put on mitomycin C and it resolved after 5 months. Sixth case again the leukoplakic OSSN, and patient was put on mitomycin C, and after 3 months lesion improved. So coming to the result, all the patients were male in this series. 3 cases were papillary variant, and 2 were predominantly leukoplakic, and 1 was having mixed form. The average size of the lesion was 9.8 millimeter. 5 patients in the series were immunocompetent, while 1 case was with secondary to xeroderma pigmentosa. Approximate duration for resolution of the lesion was 4 to 6 months. 4 cases were primary OSSN, where 2 cases were recurrent disease. 4 patients responded to topical mitomycin C, and 2 to interferon alpha 2b. So take home message is as surgery has been the traditional mode of treatment, but now with the advent of topical chemotherapy, one can start topical chemotherapy after knowing the extent and depth of lesion. And topical chemotherapy it results in less scarring, and stem cell loss is lesser compared to cryotherapy. Favored approach, especially in cases of diffuse and recurrent multifocal, again it is topical chemotherapy. And choice of which agent should be used, it depends on compliance, ocular surveillance involvement, treatment schedules, access to compounding pharmacy, and the cost. Thank you all for patient hearing. Any question or comment? Honavar sir. Thank you, sir.
नेक्स्ट ऐसे करना है प्लीज.
Good evening everyone, myself Dr. Vanna from Patna Medical College. My case is a rare case of squamous cell carcinoma of left eye presenting to our tertiary care center. My case history is a 65-year-old male from Chhapra, Bihar came to our OPD of Patna Medical College on 1st July 2022 with the chief complaint of pinkish white mass in outer aspect of the left eye, watering, foreign body sensation, decrease in visual acuity since last 6 months. No similar complaint in fellow eye. History of present illness. History of progressive increase in swelling in left eye for last 4 months in outer aspect of the left eye associated with painless gradual diminution of vision in left eye, associated with mild pain which is limited to left eye, non-radiating in nature, associated with redness. Past ocular and systemic history was within normal limit. No history of similar presentation in family. Personal history within normal limit, non-smoker. Occupation by farmer and vegetarian. General examination within normal limit. No preocular, submandibular, deep cervical lymphadenopathy was present. Ocular examination. Right eye, visual acuity 618 with pinhole 612, near vision N12, best corrected visual acuity for distance 6/9, near N/9. Rho+ was negative. On left eye, visual acuity 6/36 with pinhole 6/18, partial and near vision 1 N/12. Best corrected visual acuity 6/9 partial and near vision N9. Rho+ was negative. Slit lamp examination. Right eye was within normal limit. Left eye have positive findings are conjunctiva mass on temporal aspect, conjunctival congestion, feeder vessels were seen. Cornea nasally clear, temporally mass encroaching to the pupillary area. Description of conjunctival growth. The growth was measuring 20 mm into 18 mm, oval in shape, gelatinous surface, well-defined margin, pinkish white in color, non-tender, firm in consistency, fixed. Located primarily in temporal quadrant of the left eye, overlying the limbus and encroaching to the pupillary margin, involving the temporal quadrant of the cornea around 3 mm. Dilated fundus examination. Right eye, media, disc, peripheral retina, macula within normal limit, left eye also within normal limit. Provisional diagnosis. Left eye, non-pigmented ocular surface, squamous neoplasm. Now differential diagnosis. The differential diagnosis of OSSN includes pingicular, pterygium, chronic unilateral conjunctivitis, pyogenic granuloma, malignant melanoma and nevi. Investigations. Anterior segment OCT. Here we see abrupt transition from normal to abnormal and hyperreflective surface and back shadowing seen and increase epithelial thickness, and this suggestive of OSSN without deeper involvement. Here is the case summary, and now Coming to treatment, excision of the growth with 2 mm corneal part, 4 mm conjunctival part outside the tumor margin was carried out, removed with no touch technique. The incision was carried through the underlying tenon fossa until the sclera was exposed to the full thickness was sent for histopathological examination. Ballpoint cautery was applied to control bleeding. Primary suture with adjacent mobilization of conjunctiva by interrupted absorbable 6-0 suture. The patient was treated with topical antibiotic moxifloxacin 4 times a day, corticosteroid for 2 weeks and anti-metabolite, then followed at 3 to 6 months interval. Unfortunately, we don't have the picture of surgery, so we draw itself. Post-operative, here is the feeder vessels and 20 mm into 18 mm. 4 mm taken from conjunctival margin and 2 mm from corneal side, and wound closure with 6-0 absorbable suture. Post-operative day picture, second post-operative day picture. Vision was 6/36, uncorrected visual acuity, and conjunctival congestion was present. Histopathological examination show biopsy showing nest of squamous epithelial cell arising from the squamous epithelium and extending into the subepithelial tissue. Keratin pulse were seen. Here is the histopathological, and here we saw in left hand side keratin pulse, and here is the subepithelial extension. Follow-up, after histopathological examination, we prescribed mitomycin C 0.04% 4 times a day with punctal occlusion for 1 week on and 1 week off basis for 3 to 4 cycles. We followed every weekly for 1 month, after that monthly for 3 months. Patient doing well on every follow-up, no further growth was seen. Vision at last follow-up 6/9 partial, but we lost follow-up after 3 months. Discussion, squamous cell carcinoma of conjunctiva is a rare carcinoma, more common in middle-aged men. The incidence depend on the geographical location, 0.02 per 1 lakh, high latitude 3.5, 1 lakh at low altitude. This shows positive correlation with UV rays. Multifactorial in etiology, HPV 16 and 18, various chemical carcinogens and HIV infection may play the role. The tumor area closest to nose and temple can coexist with pinguicula and pterygium. Main barrier for prevent invasion is Bowman's layer. Rarely the lesion appear in palpebral conjunctiva. Long time may spread into globe and orbit. The treatment options for conjunctival epithelial malignancy include excision of mass with or without cryotherapy, radiotherapy, and topical chemotherapy. Surgical gold standard, no touch technique. If 8 to 4 clock hours or less of the limbus, basal diameter or 15 mm or less. Medical management, mitomycin C, 5-fluorouracil, interferon alpha 2B, and radiotherapy, extended beam radiotherapy, radiation therapy, and brachytherapy. Recurrence rate after simple surgical excision was around 24% to 50%, and reconstruction of conjunctiva may be required depending on the amount of the tissue removed. It may include using graft of the nearby tissue for reconstruction. Take home message, don't miss the lesion. Lesion elevated, acquired, progressive, extensive, fixed to underlying tissue, feeder vessels were present, must suspect for the OSSN. OSSN in young patient must rule out the HIV infection or any immunocompromised state. Appropriate early management and follow-up is important. Management need to be tailored to the individual. Thank you, and these are my references. Thank you.
Good evening. I'll be talking about what new are we doing in retinoblastoma over the last couple of years and what we currently do. I'll be skipping about intraarterial chemotherapy because that has already been spoken about. I'll be touching a bit on classification, focal therapy, management of vitreous seeds, and orbital retinoblastoma, that's new. We are all aware of international grouping of intraocular retinoblastoma and international staging system. What is new in classification is addition of H to the alphabets TNM. TNM is tumor node metastasis classification. AJCC 8 adds H, that is heritability, just bringing in genetics to the forefront in the management of retinoblastoma, especially in terms of screening of retinoblastoma, where heritability becomes very important, as well as in selective implantation. In focal therapy, we had cryotherapy earlier. For example, a small tumor of this sort would produce a large scar. And these scars are sometimes dangerous because they can have atrophic retinal holes resulting in rhegmatogenous retinal detachment. Also, if the scar is temporal to the macula fovea, then there is a risk of epiretinal membrane formation, foveal distortion, etc., thus precluding good vision. Photocoagulation is no longer done because of the large scar that is produced. Right. Okay. So you can see that a tumor is surrounded by 2 rows of large diameter laser burns that results in a much larger scar, and also there is a chance of vascular occlusion. So photocoagulation is no longer performed, and what is currently performed is transpupillary thermotherapy, which is performed directly on top of the tumor. Thus we have a very crisp scar, and the blood vessels that are passing through the area are classically patent. It does not cause visual disturbance. Now, what is new in TTT is photodynamic therapy, where we use the synergistic effect of indocyanine green in the wavelength with semiconductor diode laser to treat recurrent tumors on top of a amelanotic scar. For example, this is the scar that we always had, and on top of that, this patient has a local tumor recurrence. Obviously, when we do standard TTT, there will be less take of laser in that area. When we combine it with ICG, you can see nice regression following ICG enhanced transpupillary thermotherapy. For tumors which otherwise cannot be treated with chemotherapy for systemic reasons, etc., or ophthalmic artery stenosis, where we cannot reliably do intra-arterial chemotherapy, we can do plaque brachytherapy in these patients. The notch plaque actually sits right next to the optic nerve and is able to treat tumors which are juxtapapillary. In this patient, the tumor was overhanging the optic disc. When we use a notch plaque which sits around the optic disc and covers the rest of the tumor, you can get a nice scar of this sort. One more tumor which was juxtapapillary treated with notch plaque. So plaque is currently made in India, which has reduced the cost to less than 5% of an imported plaque. Intraarterial chemotherapy, as Bhavna emphasized, makes a huge difference in group D and D retinoblastoma. I'm not going to talk about it. Vitreous seeds were a major bugbear in the management of retinoblastoma. There are many types of seeds. The classic vitreous seeds has always been new. Now we have prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds, which is OCT based classification, and also intracameral seeds, which are depository, which simply come through the zonules and get deposited into the anterior chamber, and infiltrative are the ones which come through infiltration and contiguous infiltration of the ciliary body, anterior chamber angle, and the iris. How do we treat these seeds? Initially, we started treating them with safety enhanced intraocular melphalan injection. It showed good results. You can see a bunch of seeds gone with a couple of injections. But after we started treating patients who had extensive vitreous seeds with multiple injections of melphalan, as was described in the international protocol, we started noticing that Indian eyes would have these retinal pigment epithelial changes, which obviously, if it occurs in the macula fovea, a patient may not have good vision. And also these patients tend to have a higher chance of posterior subcapsular cataract and posterior synechiae, thus causing a bound down pupil, thus precluding visualization of the tumor. So we shifted over to intraocular topotecan, which is a spaced out injection. Instead of a weekly injection of melphalan, we give it every 3 weekly, fewer injections and hardly any retinal toxicity. This is a patient who was treated, the first case that was treated with intravitreal topotecan, couple of injections 3 weekly, good results. Similar patients, 2 doses of topotecan. So we need fewer injections. Again, this patient has completely calcified using topotecan, fewer injections, less spaced out. What if you have a refractory situation? This patient presented with this large tumor and then a bunch of vitreous seeds. After intravenous chemotherapy, the tumor has regressed, but the vitreous seeds remain almost the same. Then we bring in topotecan, 6 injections later, they're less, but they're still there. So we add a low dose melphalan, starting with 10 milligram, and if it does not respond, 20 milligram, not 30, the standard dose. And with a combination of topotecan and melphalan, you can see that the seeds went away. But even with 20 micrograms, you can still see that there is RPE change already. So retinal pigment epithelial changes are imminent to use of melphalan, and it should be used in low doses and very cautiously. In intraocular chemotherapy, there are extended indications as well. Patients who had anterior chamber seeds were earlier not differentiated to be having just depository seeds or infiltrative, and they would be enucleated. Now we do UBM in all these patients to see if they really have a ciliary body extension or not. Under anesthesia, it's very easy to do UBM, and once you confirm that there is no ciliary body invasion, we can treat these patients with intracameral chemotherapy with a very low dose topotecan. 5 microgram is what is used. If a patient indeed had ciliary body extension like this patient had, where the other eye had already been enucleated, this was the only potentially seeing eye this patient had, and he had a ciliary body extension. You can see the D-shaped pupil indicating that iris was infiltrated clinically. Of course, we treated this component with plaque brachytherapy, and for the seeds we gave intracameral topotecan, and both these components went away, and the child is doing very well after 4 years of follow-up. So this is something heroic, but of course it has to be tried in patients where the other eye has already been enucleated, because this is the only option. As a corollary, we also started finding that this massive subretinal seeds that this child had regressed with intravitreal topotecan. So for subretinal seeds, where earlier we were doing extensive TTT, which would have resulted in a large scar in this area, now has a chance of resolution with just injections without having to do TTT at all. Now about orbital retinoblastoma, where clinically we can diagnose because the child presents with proptosis, or radiologically when you do MRI you find that there is orbital extension. Earlier we were doing orbital exentration with about 70% mortality. Now with multimodal therapy, where we begin with neoadjuvant chemotherapy, where the orbital component regresses, and after complete radiologically evidenced resolution of orbital component, you do an extended enucleation and then stereotactic radiation, and finally adjuvant chemotherapy. These children have a much better chance of survival. This patient has complete optic nerve involvement right up to the orbital apex. Almost impossible to enucleate it primarily without leaving orbital residual. After neoadjuvant chemotherapy, you can see that optic nerve caliber has completely normalized, and we got a normal stump, unaffected stump following enucleation in this situation. Anterior intracranial extensions were earlier only treated with palliative therapy, where nothing else could be done. But now we have a chance of survival for these patients. This patient with cavernous sinus involvement massively now has resolved following neoadjuvant chemotherapy, and what is left is at the superior orbital fissure, which is easily amenable to treatment with stereotactic radiation. Cosmosis is a big bonus in these patients. Patients don't need orbital exentration, and with just an extended enucleation, these patients are still able to use ocular prosthesis, a customized ocular prosthesis. One more patient with exactly similar situation, where the entire eyelid involvement has normalized following multimodal treatment, and the child is good with a custom ocular prosthesis. Orbital OB also can now be cured. With all this put together, our survival rates range to from 95 to 96%, not as good as 98%, which is seen in the best of Western centers, but still we are working towards it. So what has really transformed the management of retinoblastoma is the understanding of neoadjuvant therapy, adjuvant therapy, and multimodal treatment that actually has a bearing on life salvage. For eye salvage, we have intra-arterial chemotherapy and intravenous chemotherapy, and newer designs of plaque brachytherapy added on. And for vision salvage, of course, we have intra-arterial chemotherapy, intravitreal topotecan, and photodynamic therapy. Thank you so much.
Good evening, everyone. It's always pleasure to listen to you, sir. And I think it's great honor to speak on retinoblastoma after you. And as already the Dr. Bhavna and Dr. Santosh sir has discussed the newer modalities for the retinoblastoma treatment, I think now I am going to cover just because this newer with there's a dramatic improvement in the survival rates and the globe salvage after this newer modalities. So there's a need of visual and processes rehabilitation in this retinoblastoma children. So I will going to just speak on that. Yes. So why rehabilitation in the retinoblastoma children? Basically, it's the need of continuation of care, especially for the visual and processes part after taking care of the tumor activity. And this also that this need improve the quality of life. It's provide the better cosmesis, and this better with the better cosmesis, there's a social acceptance among peer groups, and it's boosts the self-esteem of the children's, and even they become source of inspiration for the other children's. So this is the article that published by Dr. Himani Dingra. Our hospital is also part of this studies, and in this study what we found that the most important factors that is affecting the quality of life in these retinoblastoma survivors is like the visual impairment and inoculation surgeries after the disease. So the rehabilitation part actually, there's a two aspects of this part. There's the processes rehabilitation and the visual rehabilitation. So this is a multidisciplinary approach that need for the visual and processes rehabilitation of the retinoblastoma children. So coming to the processes rehabilitation, the processes fitting, there's some specific consideration when you are talking about the prosthesis in the retinoblastoma children, because the processes fitting is required early in retinoblastoma children to prevent the orbital bone growth retardation. Repeated change and fabrication of large size processes is needed to compensate for the bony orbital growth with age. Postoperative, any adjuvant radiation to the orbit cause socket contracture, and that can make prosthesis fitting difficult in the children receiving this radiation. So ocular prosthesis can be prefabricated, that is the ready-made prosthesis made of the plastic material, and one is the customized ocular prosthesis. So customized ocular prosthesis has better compared to the prefabricated, because it will give a snug fitting to your orbit, and there's a less chance of the socket infection and discharge, and a better cosmesis. So this is a retinoblastoma child. After the chemotherapy, and there was again the recurrence of the tumor, and the patient finally underwent inoculation for group E tumor, and after this secondary inoculation, patient received customized ocular prosthesis, and he is doing well. Secondly, for the prosthesis rehabilitation, this is the child presented to us with the post-inoculation socket syndrome, and she's 8-year-old RV survival. And when you see there's a recent also the implant extrusion is there, and there's a lower fornix selving with the volume loss, and this patient has received the just fornix from implant, PMMA implant with fornix formation suture, and now the child has the stable COP. So basically, this is also another lady, she's also 25 years old lady with the RV survivals and had the similar post-enucleation syndrome. And in this patient, sometimes the imaging is important to see that what is the volume there, and also to see that any, in the earliest phase, the recurrence also. So imaging has a role in that. So this patient underwent the dermis fat graft, and you can see in the healing phase that dermis graft fat is well taken except in the center part, and the patient is still under the treatment. So it's a DFG is not, it's like without complication, it carries some complication. There's a chances of graft melting, there's a chances of infection, and also there's a chances of this, the fat atrophy, and along with that, this hair growth, if that epidermal part has left with the graft. So this is the child with the 12-year-old retinoblastoma survival, and this already I have shown in the earlier session. So she has basically the dry socket post-irradiation, and this patient is managed by the surface management with MMG because implant is already there. And she has achieved almost adequate surface. Maybe one sitting MMG is more required for this child. As sir told that now we are doing extended enucleation at the place of exentation with the advent of the multimodal management of orbital retinoblastoma, but still in the some children when there's after chemotherapy, if still there's a orbital tissue has that active and then the child needs this eyelid sparing exentation. And in this case, the exentation process is required. It could be the glue assisted and a spectacle mounted. And there's also need of this education about the processes care education. The many time these children's, the parents are like not keeping regular follow-up for this prosthesis, and they don't want to clean the prosthesis, they are afraid of removal of prosthesis. So you have to basically educate them about the removal technique and cleaning instruction with the periodic cleaning with the soap water and the polishing at the every 6 months. And the regular follow-up with the ocularist. And at every follow-up, this child should be seen by the treating oculoplasty surgeon also to see the any early tumor recurrence in these cases. So coming to the visual rehabilitation. So visual rehabilitation is an important part in the rehabilitation of the retinoblastoma children, because the visual rehabilitation affects the psychosocial component of the child development, cognitive development. And like this children has already treated with the treated with the chemotherapy and radiation, but chemotherapy with the TTT, but the child has the macular tumor. So the vision is very less in this patient, in this eye. In the other eye, there is a diffuse RP atrophy with the flat scar, and again the vision is the hand movements. So these children need basically the low vision therapy for the visual rehabilitation. So other thing is that there's a need of occlusion therapy for the stimulational deprivation amblyopia. There could be astigmatismus begin with, because astigmatismus is the second most common presentation of retinoblastoma. Other thing, it could also be sometime because the periocular injections, and that can lead to the fibrosis, and that can lead to the astigmatismus. So that astigmatismus correction needed after once the treatment of retinoblastoma got over, whether with the surgery or prisms. Refractive errors should be corrected with the glasses to prevent any amblyopia further. And if there is any cataract and the tumor has been regressed, the cataract surgery should be done with the minimum vitreous disturbance. So low vision therapy again includes the optical devices, non-optical devices, and the smart vision glasses. There's we have the in-house facilities of this, and the children are doing great. So there's also the children, this is learning the braille there, they're working on the computer, they can write. and they can also do calculation on the braille. So, and they can come into the mainstream of the learning education system. So there's also recently there's a smart vision glasses is there that has basically the inbuilt camera in that, and on the left arm of that there's a braille coded switch are there that can basically tells about the things around the walking direction, the picture, they can also restore the memory of the person, that person, or can take the pictures of that and helps in the reading and all. There are the several, so she is like Priti Monga, the founder and CEO of Silver Linings. She is herself a blind, and she is the author of the books like The Flight Without Sight, and she is like the main workings, this motto that to basically to empower all these the childrens, and these all the organization helping the children. So we should just send to the children there for rehabilitation. After the visual and prosthetic rehabilitation, there is also need of the social rehabilitation. So this child underwent enucleation, has artificial eye in another eye, but doing well in the class, even getting the certification of achievement. So this kind of rehabilitation what we need for our RB survivors. She's a stage 4, she's a like girl having a stage 4 disease. I don't know whether she is going to survive or not, but we should do all the things that can bring a smiles on her face. That's matter most. So we should take the place that let's bridge the gap in the care of the children, and should hold the hand of these children till they get final rehabilitation and till the end of their life. So these are our RB team, and I acknowledge them. Thank you. Any questions? Thank you.
Chairperson has also left, so I thank everybody for staying on so long. And Santosh for coming in just now.
No, just I came to